Hello, I'm Dr. Stephen Pipe, pediatric hematologist at the University of Michigan, I'm professor of pediatrics and pathology. Severe hemophilia A is primarily treated prophylactically because the main manifestations of hemophilic bleeding is bleeding into joints or sometimes serious internal bleeding, including intracranial hemorrhage. We aim to initiate prophylaxis with two forms of therapy that have been available to us in recent years. Traditionally, it had been factor concentrate replacement, predominantly using recombinant factor VIII products. The challenge there, of course, is that they require intravenous administration. And if we look back over the history of hemophilia A initiation, particularly in younger children, it's just practically difficult to start prophylaxis until patients are between about 9 to 15 months of age. So what that has left is a sort of a treatment gap where from birth until we get prophylaxis started, we're just in a reactive mode, treating infants when they actually have a bleeding event. We have now shifted to using a novel substitution therapy called Emicizumab. This is a bispecific antibody that substitutes for the function of factor VIII. And this has been approved in the US for several years. But in the clinical trials, we had very little data on the youngest infants being treated with this agent. So what the VIII study really sought to do is to develop some prospective data in these youngest infants to demonstrate the efficacy and the safety of this approach. So we enrolled 55 infants in this study. They were all under the age of 12 months at the time of enrollment. And they've now been followed for 1 year on emicizumab prophylaxis. They all received a standard loading dose. It's a once weekly subcutaneous injection. And then all of the patients during the first year of follow-up were on the same maintenance dose. And if we look at just the youngest infants, so those who were under 3 months of age, the great majority of these were previously untreated patients. And the reason that's important is early in life when infants first start getting exposures to factor VIII containing products, they can mount an immune response in which they develop neutralizing antibodies against the factor VIII product. Emicizumab looks nothing like factor VIII. So even if they did get some exposures to factor VIII, these inhibitors would not have the same consequence because it wouldn't interfere with the continued prophylactic benefit of emicizumab. So one of the first questions was, can we achieve sufficient plasma levels of this subcutaneous administered bispecific antibody so that we would get the efficacy that we're looking for? So as it turns out, the infants actually achieved very good plasma levels. After the loading dose, their plasma levels went up to about 62 micrograms per ml. So even in these very youngest infants, we were able to get up to therapeutic levels that were really excellent. Another question was, the way emicizumab works is it's a bispecific antibody in which one arm of the antibody recognizes plasma factor 9A, and the other recognizes plasma factor 10, brings them together, and catalyzes the clotting reaction. And infants actually have low factor 9 and factor 10 levels, particularly when they're under 4 months of age. So the question was, would this have efficacy when the baseline factor 9, factor 10 concentrations were low? And what we observed is that there was no impact on factor 9 and factor 10 concentrations. And actually, we did get the efficacy that we were looking for. So the way we evaluate effectiveness or prophylactic strategy in hemophilia is we look at bleeding events, and we tracked multiple bleeding events over the course of this trial. And what we observed is that the treated bleed rate was an annualized bleeding rate of 0.4. This is some of the lowest bleeding rates that have been observed in an age group like this. If we look at all bleeds, it was an ABR of 2.0, but really impressively, there were no treated spontaneous bleeds. This is one of the hallmarks of hemophilic bleeding is spontaneous bleeding, and none of that was observed in the follow-up on the trial. And there were also no treated joint bleeds. If we look at the participants who had 0 bleeds across all of these bleed categories, more than half of the infants had no treated bleeds through the 1 year of follow-up. And if we look at the hallmarks of hemophilic bleeding, 100% of the infants had 0 treated spontaneous bleeds, and 95% of the infants had 0 treated joint bleeds. So we definitely saw the efficacy of this prophylactic therapy across the infants that participated. Importantly, these infants, all in a vulnerable age group, as we mentioned, no intracranial hemorrhage have been observed in any of the infants who participated in the trial. We did see various levels of adverse events, as you do in clinical trials, but anything that was treatment related were very low grade, and what was observed are what we call injection site reactions. This is a little bit of redness or irritation at the site of the injections. It occurred in a minority of the infants. It was transient, and none of the infants were discontinued from therapy because of it. In the other Haven trials, there have been a low rate, but some observation of anti-drug antibodies that can be mounted against emicizumab. Usually these don't interfere with the efficacy of the product, but we did look for that in the trial, and all 55 participants were evaluated for this, and none have tested positive for anti-drug antibodies to emicizumab. But the other immunogenicity we wanted to look at was against the factor VIII molecule. And so far, of the 24 participants who've been tested for factor VIII inhibitors, we've only had 2 that tested positive. They were both in those youngest infants, the previously untreated patients. And this is actually quite a low factor VIII inhibitor rate. I think Haven 7 has definitively shown that emicizumab is efficacious. It's well tolerated in infants with severe hemophilia A. And what we're going to do now is we're going to follow this population of infants over the next 7 years. And what that's going to allow us to do is we're going to be able to look at the continued natural history of what happens if they remain on emicizumab from initiating very soon after birth all the way through early childhood. We'll be able to see, what happens with inhibitor rates over time, any consequence related to that. And then importantly, we're going to be able to evaluate joint health outcomes over a multi-year period. And this will give us a first glimpse of whether initiating prophylaxis at a very early stage like this has an opportunity to abrogate some of the cumulative joint disease that is typically seen in hemophilia.